We are on live, everyone. Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 17th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Meenakshi and Ms. Anshika, ma'am. Hi, both of you. Thank you so much for joining. As we have completed the anterior segment topics already, both anatomy, physiology, and diseases, now it's time to step into the posterior segment. And the first topic in the posterior segment, and especially for today, is vitreous anatomy and diseases. So I'm very happy to welcome our moderator, who is our very own Anshika ma'am. Anshika ma'am, thank you so much for accepting to moderate today.
Thank you, Govinti.
So introducing Anshika ma'am. Anshika ma'am is known for a 12 plus years of experience, both in clinical as well as in teaching. Ma'am has worked in Shankar Netralaya. Ma'am has teaching experience from Yemen, the Dr. Agarwal's Institute of Optometry, the Shankar Netralaya Academy, the SRM Institute, and especially in Dr. Agarwal's Institute of Optometry, ma'am is being an associate professor and academic head. So Anshika ma'am, what are you looking forward for the topic today, ma'am?
We are looking for a good revision of vitreous anatomy for any students who are whether in the third year or second year, or for the first year students who are reading vitreous for the first time. And it would be a definite help for the second, third years and interns to understand how you can relate to clinical features when you see a patient at the OPD. So without further delay, I think we can start today's topic. So we are having Ms. Rajeswari present the topic today. She's a third year student. So, Ms. Rajesheari, can you please start your presentation?
Over to you, Rajeshwari.
Thank you, Komal ma'am. Good afternoon, everyone. I am Rajesheari, third year student from Dr. Agarwal Institute of Optometry. Today, we are going to discuss about the topic of vitreous anatomy and disease.
Rajeshwari, sorry to interrupt. Slightly be louder.
Moving on to the introduction part. Basically, the vitreous humor is an intense, transparent, colorless, jelly-like hydrophilic gel that performs important optical as well as structure function within the eye. It helps to maintain the shape of the eyeball, keeps the retina pressed against the pigment epithelium, and allows the light to pass through with minimal scattering. The vitreous cavity is bounded anteriorly by the lens and ciliary body, and posteriorly the retina. The vitreous weighs approximately 4 grams. This shows the gross anatomy of the vitreous. This composition wise, the vitreous is an extracellular matrix material consisting of about 90% of the water, within the remaining 1% made up of collagen fibrils, hyaluronic acid, soluble protein, and other macromolecules that helps maintain its structure and transparency. Learning about this composition. Cell of origin of the vitreous. Surface ectoderm contributes cells from the cell. Angular neuroectoderm give rise to the retina and ciliary epithelium, which plays a role in vitreous formation. Mesodermal cells at the anterior limb of the developing optic cup. This cell lies between the surface ectoderm and neuroectoderm during early eye development and contribute to vitreous structure. Mesodermal cells migrating into the optic cup through the fetal fissure. These cells enter along with the haloid vascular system, contributing to the formation of the primary vitreous. Vitreous body is the largest and simple connective tissue in the human body, present a single transparent gel filling in the vitreous cavity, composed mainly of water, collagen type 2, and hyaluronic acid. These are the division of vitreous: haloid layer, haloid membrane, cortical vitreous, medullary vitreous. Haloid layer. Now, it is not a true membrane. It is the outermost concerned surface of the vitreous. It contains connective tissue like fibrils running parallel to the surface. Two components. Anterior haloid membrane. It lies just behind the lens capsule. Posterior haloid membrane lies adjustment to the internal limiting membrane of the retina. Cortical vitreous. It located in the peripheral zone, more concentrated fibril vitreous. It contains type 2 collagen fibrils, sodium hyaluronate, providing viscosity and elasticity. It represented 2% of the total vitreous volume. It contains important structure like vitreous base, retrolental space, area of Martigeni. Medullary vitreous. It forms the majorly of the vitreous body. Its similar composition to cortical vitreous, but less fibular, cell-free, provide bulk of the gel structure. Vitreous tract. It represented fine sheet-like concentration in the vitreous. In young eye, gently curves. In adults, become more sinus, extensive and visible. Clockwork canal, most important tract. Primary vitreous, remnant of the allied artery pathway. Anterior attachment to the posterior lens capsule near the hyaloid capsular ligament vitreous. Posterior termination in front of the top optic disc. Retrolental tract attached anteriorly to the posterior lens capsule near the hyaloid capsular ligament at the boundary of the platelet fossa. It runs backward toward the central vitreous, terminant in front of the optic disc. It appears as a reflecting membrane known as the membrane placenta of represented the best defined and most optical visible vitreous tract. Coronary tract. It attaches to the coronary ligament, a circumferentially band joining the inner face of the posterior third of the ciliary process to the anteriorly alloidal membrane. It runs backward in the central vitreous surrounding the retrolental tract. It less reflective and non-distantly visible optically. It represents the second concentric tract around the retrolental tract. Median tract. It attaches anteriorly to the median ligament which links the anterior alloid membrane to the mid-zone of the pars plana. It extends backward a spine around the coronary tract. It lies peripheral to the coronary tract, optically faint and less prominent. Tunal tract. Outermost concentration of the vitreous tract attached circumferentially at the ora serrata. It forms a comparatively more reflecting membrane than the inner tract. Extend posteriorly around the median tract into the central vitreous. Represent the boundary of the peripheral cortical vitreous. Topography subdivision of the vitreous space. Retrolental zone. Locate behind the lens. Boundaries. Platelar fossa, tragus retrolentis. Contains clockwork canal. Represented the anterior vitreous. Intermediate zone. It lies between retrolental as prerental zone. Boundaries. Episclerally anterior haloid, posterior pars plana. Tragus periretinal. Represented the medial vitreous. Prerental zone. Lies adjustment to the retina. Boundaries. Retina. Tragus preretinal. Represented the posterior vitreous cortex. Vitreous attachment to surrounding structure with varying degrees of trimness. Major attachment style. Vitreous base, optic disc margin, foveal region, posterior lens capsule, retinal vessel, general posterior pole. The vitreous has trim, moderate and weak attachment. The strongest attachment is at the ora serrata region, followed by the optic disc and macula. Vitreous base is the strongest and most clinical important attachment of the vitreous. Features. A 3-4 mm wide three-dimensional zone straddling to the ora serrata, located 1.5 to 2 mm anterior on the pars plana, 2 mm posterior on the peripheral retina temporally, 3 mm posterior on peripheral retina nasally. The vitreous cortex, collagen fibrils, and intercrete tightly in the region. The functional vitreous base extends several millimeters inward into the vitreous body. Clinical importance. Difficult to detach even in posterior vitreous detachment. Transition in the region contributed to retinal tears at the ora serrata, dialysis, peripheral retinal degeneration. Move on to the disease of vitreous. Vitreous liquefaction. Vitreous liquefaction is the most common degenerative change. It increases after age 50 and is also seen in myopic degeneration, retinitis pigmentosa, post-inferiorly stage, trauma, and thermal effects such as dithyramia, photocoagulation, cryotherapy, and radiation. Liquefaction weakens the vitreous gel and residuo disposed to collapse, and posterior vitreous detachment. Posterior vitreous detachment is separation of the cortical vitreous from the retina posterior to the vitreous base. It occurs especially after 65 years, more in aphakia and myopia. Synaptic fluid accumulates between the posterior haloid and internal limiting membrane, creating the detachment. Clinical signs: flashes, floaters, viscous rings, optical clear space behind the lens, collapsed vitreous. Complication: they are retinal breaks, vitreous detachment, retinal hemorrhage, cystoid maculopathy. Management: reassurance of uncompliant cases. Warn about retinal detachment symptoms, retinal tears require laser. Vitreous hemorrhage and retinal detachment are treated accordingly. Detachment of the vitreous base, anterior vitreous. It occurs after blunt trauma causing abrasion at the vitreous base, often associated with vitreous hemorrhage, anterior retinal dullness, and possible lens dislocation. Mucus polytens. Physiologically, vitreous opacities usually remains of primitive hyaloid vascular disease tissues. Its patients see fine dots and lemmatonous floaters moving across their visual field, especially against bright background. Resistant hyperplastic primary vitreous. It results from failure of the primary vitreous and haloid system to recur combines with posterior vascular meshwork hypoplasia. It can be anterior, posterior, or mixed. It presents with leukocoria, retrolental fibrovascular tissue, microophthalmos, and transitional changes. Inflammatory vitreous opacity. It's seen in anterior vitreous, posterior uveitis, pars planitis, panuveitis, and endophthalmitis. Inflammation leads to exudate entering the vitreous, providing hairs and decreased transparency. Vitreous arcade and contention. Its most common causes of vitreous opacity due to concentration of collagen fibrils from senile, myopic, traumatic, or post-inflammatory degeneration, often accompanied by liquefaction. Amyloid degeneration. A rarer condition where amorphous amyloid material is deposited in the vitreous part of the systemic amyloid organism. Opacities appearance linear with foot plate attachment to the retina and posterior capsule. Asteroid ilosis. It characterized by small white spherical calcium lipid deposit suspend in vitreous gel. It usually unilateral, asymptomatic, seen in elderly. Associated with diabetic and hypercholesterolemia, no effective treatment required. Sinus scintillation. It occurs in previously damaged eye after trauma, hemorrhage, or inflammation. Vitreous become liquefied and fills with cholesterol crystals that settle inferiorly but swirl in with eye movement, giving a golden rain appearance on ophthalmoscope, typically symptomless and untreatable. Red cell opacity. It results from small vitreous hemorrhage or remnants of large hemorrhage. It's seen as tiny red or brownish mobile particles. Vitreous hemorrhage. Vitreous hemorrhage results from bleeding of retinal vessels and may appear as pre-retinal or integral hemorrhage involving the anterior, middle, posterior, or entire vitreous cavity. Causes of vitreous hemorrhage. Retinal tear, PVD, and retinal detachment often produce associated with vitreous hemorrhage. Trauma, blunt or penetrating, with or without intraocular origin body. Inflammatory disease, which is such as acute choroiditis, peribillitis, or secondary to uveitis. Vascular disorder, which is hypertension retinopathy, CRVO. Metabolic disorder, which is notably diabetic retinopathy. Extensive AMD, which is especially with high risk CNVM. Blood dysplasia, which is anemia, leukocoria, polycythemia, sickle cell retinopathy. Bleeding disorders. Purpura hemophobia scabies. Neoplasm, retinoblastoma, choroidoretinal melanginoma may bleed due to necrotic vessel rupture. Other causes: core disease, radiation retinopathy, retinal capillary aneurysm. Clinical features. Symptoms: floaters of sudden onset in the middle hemorrhage, sudden painless visual loss in massive hemorrhage. Clinical signs: distance direct ophthalmos, black shadow in small slits, absence of red reflex in large, direct and indirect ophthalmoscope, visible blade in vitreous or non-visualization of fundus. Slit lamp, normal anterior segment, reddish mass in vitreous in large hemorrhage. B-scan ultrasonography essential to confirm vitreous hemorrhage and ruled out. Fade of vitreous hemorrhage. Complete observation, clear simultaneously in 4 to 8 weeks. Organization, persistent, recurrent, bleeding leads to yellowish white bleeding. Complication, liquefaction, degeneration, cell glaucoma. Retinitis proliferating may develop leading to transitional retinal detachment. Management, convective management. Bed rest with head elevation to allow blood to settle inferiorly. Once blood settles, perform indirect ophthalmoscope, identify and treat the underlying causes. Definitive treatment. Treatment of root causes. Brass plana vitrectomy indicates when hemorrhage state becomes cement. Yearly vitrectomy requires if associated with retinal detachment or serve proliferative disease. Vitreoretinal degeneration. This includes a group of hereditary disorders affecting the vitreous, retina, and sometimes systemic connective tissue. Example: Warner syndrome, Stickler syndrome, Spear-Goldman syndrome, similar extensive vitreoretinopathy. Dominant neovascular inflammatory vitreoretinopathy, dominant vitreoretinoporoidopathy. Warner syndrome. Inherent. Autosomal dominant. Ocular feature. Liquid vitreous with constant vitreous membrane. Peripheral retina show narrow, seated vessels and pigmented spots. Choroidal atrophy may be present. Cataract may occur as a late complication. Stickler syndrome. Inheritance, autosomal dominant, ocular features, liquefied vitreous with marked synergies. Vitreous cavity looks optically empty. Progressive eye myopia is common. Radical lattice-like degeneration, which pigmentary change and vessel heating. Bilateral retinal detachment occurs in 30%. Occasionally, ectopia lentitis. Pre-senile cataract in 50% of cases. Systemic features. Acrofacial abnormalities, flat nasal bridge, maxillary hypoplasia, cleft plate, high arcent plate, arthropathy, stiff, painful, hyperextensible joint, hearing loss, mitral valve plus, Crave Goldman syndrome, inherit autosomal recessive presentation, childhood onset with characteristic features. Vitreous shows synergies but can not optically empty. Retinosis, both central and peripheral macular change may be retinitis pigmentosa, like pigmental change, are prominent. E or G is subnormal. To conclude, vitreoretinal degeneration represents a diverse group of hereditary disorders affecting the vitreous structure and retinal integrity. All thought each condition has distinct clinical features. They commonly present with vitreous liquefaction, peripheral retinal change, and a high risk of retinal detachment. Yearly recount is especially in syndromes like Stickler and Manner is essential to prevent vision-threatening complications. Genetic counseling, regular retinal monitoring, and timely surgical intervention play a critical role in large-term visible prognosis. Thank you.
Thank you so much, Rajeshwari. Can you please unshare your slide? Yes, thank you. Now I request the moderator, Anshi ma'am, to add your valuable clinical inputs, ma'am.
The presentation was very good, Rajeshwari, but I would like all the students to make a note when you're presenting not to just read the slides. So you had a lot of information on the slides, Rajeshwari. Vitreous does look like a very small part of the eye to us, but then it does have a lot of factors which we have to look, and it is one of the main reasons where we can find out if there are any retinal tears or retinal detachments. So we have a few points in anatomy that we should remember is vitreous, if it becomes more liquefied, the patient will come with complaints of floaters. Or where does the vitreous strongly attach? So the cases or the places where it is strongly attached is the optic disc, the macula, the retinal vessels, and the vitreous base. And we also need to remember that PVD is most common after 50 years of age. So knowing where the vitreous can be pulled and understanding the symptoms of a patient can help us halfway solve the problem that the patient has. So a few red flags whenever we are trying to observe a patient or whenever we are doing retinal evaluation, ask the patient for sudden floaters, look for any kind of flashes or photopsia, cobweb-like shadows or cobweb-like floaters if there are any, or if there is any smoke-like vision, or if there's any peripheral field defects which they complain of, or sudden loss in vision. Make sure that when you have these kind of complaints, you also keep in mind that vitreous could be affected. So already she's discussed the signs that we have, which is like the tobacco dust or vitreous synergis or vitreous cells. So I think she's covered quite a lot. Any questions from your side, Meenakshi?
Am I audible, ma'am?
Yes.
There are a few questions from the YouTube, ma'am. I'll read out for you. The first question is, we know any issues with vitreous will relate with floaters. But then what kind of floaters are considered to be alarming?
Okay, any kind of floaters are considered to be alarming for that matter. So you have different kind of floaters. You have cobweb shaped floaters, you have round or other spot type floaters, you have ring shaped floaters. But most important, cobweb like floaters or black floaters are at least seeing stars in the sudden vision. So those are something that should be alarming and the patient should go for a retinal evaluation.
Thank you so much, ma'am. The second question is, how does complete and incomplete PVD differs and when should we pay attention?
So a complete PVD and an incomplete PVD, most easiest thing would be to notice in a OCT if possible, because when you see in an OCT, a complete PVD will just have the vitreous completely detached, whereas the incomplete PVD, you will see it still attached to one particular part of the retina. And it is important because it just kinds of shows that there's traction, there's a pull on the retina. So whether it is IPVD or complete CPVD, it is always important that a patient does be in complete evaluations regularly, because you never know where IPVD can become a CPVD. So it should be posing a higher risk. The patient should not be on a chance of complete retinal tear or attraction.
Next question, ma'am. Does vitritis affect vision or contrast?
It will affect contrast, it will affect vision, because it's an optical media. So light has to pass through the pupil and then it goes through the lens, aqueous lens, and then crosses over the vitreous. Vitreous being a completely transparent liquid, for the light to reach the retina, it has to be clear. So if there's any kind of vitreous floaters or any kind of shadows or any kind of degeneration in the vitreous, it will definitely affect the vision as well as contrast both.
Thank you so much, ma'am. To add on with the previous question, is there any chance that incomplete PVD tend to become a macular hole?
Yes, if it is not taken care of completely, it can cause huge damage. It can pull the retina completely. So, yes, if it's not taken care of or not observed.
Thank you so much, ma'am. And the last question is, will light clear up the vitreous hemorrhages on its own?
Yes, hemorrhages generally clear up on its own, but it takes a long time. It could be within 2 weeks to 2 months, depending on the kind of vitreous hemorrhage that they have. But again, it does not mean that you don't go to an ophthalmologist or an optometrist for an evaluation. Being in continuous touch is more important, because that's the part where the first question, the previous question that you asked, vision is affected or not. So if it's not taken care of, any damage to the vitreous, if it's not taken care of, it will directly affect the vision. So being under supervision is very much important.
Thank you so much, ma'am. That's all with the Q&A. Gomati, you have something for ma'am? Gomati, you're muted.
On mute.
I hope I'm audible now.
Yes.
So no, Meenakshi, nothing from my side, but thank you so much for the Q&A session. And Anshika, ma'am, thank you for pitching in as the moderator for the day, ma'am.
Thank you so much.
Dear audience, thank you all for your continuous support for our Optometry series. This episode is the last one for 2025. We will meet you with more episodes, especially on the posterior segment in Jan 2026. Wishing you all a Merry Christmas and a very Happy New Year from Optometry series team and the Dr. Agarwal's Institute of Optometry. If you need any clarifications on the admissions, please contact the number that is given in the description box. If you like this video, give a thumbs up and share with all your friends. Meet you all in the next episode. Thank you, team. Bye, everyone.
Thank you, Anji, ma'am.